Next few questions will be about time constants. Actually, you know what? First, I'll get everyone to just take a minute, write down in 1 minute everything, just facts about time constants. You might want to draw a few curves, explain what it is, what are the numbers for 1, 2, 3, 4 time constants, and maybe how they relate to the lung.
So time constant is time taken for a process to reduce by 63%, or also time for an exponential process to complete if the initial rate of change is maintained.
Fantastic. And how would you describe it for the inflation of a lung?
So specifically when it comes to the lung, compliance equals to, time constants equals to resistance times compliance.
Fantastic. Are you able to, now you may have done this already, but draw a runaway, a wash-in and wash-out curves. These are often the curves that occur, the exponential curves that occur in medicine.
Oh, sorry, I have been muted. Wash-in curve will be most commonly like volatile curves where it's very steep at the start and then it plateaus off.
Mm-hmm.
A washout curve will be like drug clearance where it's steep initially and then goes down.
Mm-hmm. And a runaway curve?
And a runaway curve is similar to the washout, but just a mirror image, so the other way. Flat on the x-axis first, and then it shoots up right at the end. A bit like the ICP elastance curve. Yeah,
good. And so examples, and you gave examples. So yeah, runaway, bacterial growth, wash-in curve, as we've seen in all volatile wash-ins, and washout. Volatile washout would be a good way of doing that, or denitrogenation. Good. So these are examples of the curves which you expressed. Do you know the formulas for each of these curves? So the formulas: y equals e to the kx, and then the next one is 1 take away e to the negative kx, and then e to the negative kx. And we gave some real world examples. Now you mentioned the value 63% roughly is one time constant for a process to complete. What's 2, 3, and 4 time constants roughly?
So 86, 95, 98, and 99.
I think it's just 99 for the fourth one.
Oh, okay.
Sorry, 95 and 99.
Yeah.
Fantastic. Good. Now, actually, I'll ask everyone this question. Imagine alveolar. So you've got Hey, can everyone see this screen? Yeah, there you can. So fast and slow alveoli. So imagine you've got alveolar A, or alveolus A and alveolus B. Now, the time constants of A to B, let's say it's 1 to 2. Now, which alveolus, will achieve a larger volume? So I want you guys to have a think of that. Let's say, yeah, just have a think about that.
Sorry.
1 second.
Do you mean larger volume of change, larger total volume, or volume per unit time?
Sorry, yeah, larger total volume. That's really good to get that, because this is I guess where the trick lies. Mason, what do you reckon?
So I would expect that B will end up having, the larger volume of change I would expect would be B, because by having a larger time constant, a contributor may be that it has a larger compliance, and so it can achieve a larger change in volume for a given change in pressure.
Okay, so let's say it's just the total volume that this alveolus will achieve. What does that depend on?
So the total volume is purely dependent on compliance and has no contribution from resistance.
Yeah, fantastic. So yeah, I remember this being in nuns where they kind of talk about this, that, the fact that time constants, while they will reflect what the alveolus may be in a limited amount of time, if you had all the time in the world, then the time constant has little bearing on has no bearing on the absolute total size of this alveolus. It is absolutely dependent on compliance. You could have something with, super high resistance to make a time constant very, very long. But if the compliance is very, very large, and you gave a lot of time to inflate that high resistance lung or high resistance alveolus, it would eventually reach a very, very large volume. So that's kind of like, that's just the trick question.
So as the answer to this, I don't know until I know the components of each of their time constants, how much is from resistance and compliance.
That is exactly right. It is compliance that will be the determining value, and you cannot know the compliance through just knowing a couple of ratios. Does that make sense to everyone? I thought this would be one of those like little trick questions if you ever get in the Viva. So the next section here is describing the elastic properties of the chest wall and plot the pressure volume relationships of the lung, chest wall, and the total respiratory system. So this was, I think, seventh edition of West, page 104. And so let's just go through a few of these questions. Again, take a minute to answer. Actually, what do you reckon? What's the intrapleural pressure at FRC? It's always relative to atmospheric pressure.
So I would say the intrapleural pressure of FRC would be -5 when it's relative to atmospheric.
Right. I had trouble hearing you, but I think you said -5 centimeters water. Is that right?
Yeah.
Yeah, fantastic. What happens to this intrapleural pressure when you get a pneumothorax?
So you essentially just basically have a hole, and so then there would be an increase in the intrapleural pressure. So in relative to the atmospheric pressure, it would be 0.
Yeah, good. It's 0 because essentially once you get the hole, there's now no negative pressure inside that intrapleural space. It goes to 0. Fantastic. Now, I looked at this graph in West, and I thought this would be it's a really busy graph, and it's something that's a bit annoying to explain. So I thought I'd get you to kind of explain what this graph was saying, because it is a bit tricky. There's a lot of lines going everywhere, but I can imagine that you can get this in the exam, and all you have to do is say true statements and try to simplify this graph as best as possible. So I might get you to do that, Ginny. But firstly, which way does the lung want to recoil? And which way does the chest wall want to recoil?
So the lung would recoil inward.
Yes.
And the chest wall would recoil outward.
Fantastic. Now, what I want you to do now is, so normally when we're live, not on Zoom, I get people to try and draw this graph, which is obviously a bit difficult to draw. But I want you to go ahead and describe this graph for me. Yeah, just speak as closely and loudly to the mic as you can.
Okay, sorry. So I'll break it down, I guess, graph-wise. So on the x-axis, there's the airway pressure, which is the centimeters of water, and then you have the vital capacity percentage and the total lung capacity.
Fantastic.
So we have 3 lines. One is the chest wall, and then there's the lung, and there's the lung and chest wall. So if we're just looking at the chest wall, you start off with the airway pressures of like -20, and when it starts to get about maybe 75% of the vital capacity, the airway pressure is 0, and when it gets to about 100, it gets to +5 centimeters of water.
That's great. And so first of all, I like the way you're describing that. So you're just telling me true facts. You're saying that the x-axis is negative airway pressure, airway pressure in centimeters water, and then on the y-axis you've got volume, but they're using it as % of vital capacity or total lung capacity. So good, true statements. And then you've gone on to highlight each of the curves, which I think is really great. And so I like that you went straight to the points that are interesting as well. So at 0 lung volume, there's a lot of outward recoil. so that, there's a lot of negative pressure generated by that. By the time it gets to 75% of lung capacity, that's the maximum, that's where the resting state of the chest wall wants to be. So any further inspiration, that chest wall is going to recall inwards, creating that positive pressure that you were saying. Keep going.
So at the lung, we start at 0 centimeters of water, and when we're at the maximum vital capacity, we're probably about 25 centimeters. And when you're looking at the lung and the chest wall combined, I guess at the FRC, there's an equal inward and outward pressures on the lungs.
And that's good. And for the lung and chest wall, it seems to me that that's the most interesting part of that intersection. The fact that FRC is defined by the outward recoil of the lung, the chest wall is balanced by the inward recoil of the lung. And that seems to be the most interesting part of that lung plus chest wall line. And then how about the lung?
In the lung, it starts at 0 and it gets to 25 centimeters of water. The pressure when it's at 100% vital capacity. And I guess when it intersects, I can't really describe that as much.
and that's fine. Like to me, when I look at the lung graph, I mean, I think the important points again are the fact that at FRC it balances with the chest wall. It never gets to a negative pressure because at 0 volume it simply collapses. And just the nature of the lung means that it's never going to get to cause a negative pressure. It's always in that positive territory for this particular graph.
Okay.
But good. And so this is a busy graph. I can imagine you're going to get lots of different diagrams or pictures in this exam, and your ability, even if you're unfamiliar with something, just to be able to describe it with true facts, name the what are we measuring here on the X and Y axis, and what are the interesting points, and what are each of the lines, and just being able to describe each line on the graph as it is. I think that's just a really useful skill to have, and one of the techniques of this exam. Explain the vertical gradient of pleural pressure and its significance. So here are a few more questions, and again I'll get people to just write down some answers. I really want everyone to have as much of a go actively stating out answers or writing them. Catherine, what do you reckon? How does the intrapleural pressure change from apex to base of the lung?
So I sort of drew that picture that you had up on the slide before, but it basically becomes more negative as you move from the base towards the top. So about -2.5 centimeters of water at the base, and there's a gradient up to about -10 centimeters of water at the top. And I believe it's essentially just due to the effect of gravity on the lung. So it's more apparent in the upright lung than if you're supine, or particularly if you're prone. It pretty much abolishes that gradient.
Yes.
And it means that the base of the lung is easier to inflate than the top of the lung because it's on a steeper part of the compliance curve. So you've got a larger change in volume for unit change in pressure. Fantastic.
So, yep, that's the steeper part of the compliance curve. That's simply why it means that any given pressure, you get more volume. So you just mentioned, so which part of the lung has greater ventilation? It's the base. And which part of the lung has larger alveoli?
The apex of the lung has larger alveoli.
Yeah, and so I remember, I guess I've had people who, when you think about the lung and you think there's going to be large alveolus at the apex and small at the base, people might get confused by the fact that that's smaller, therefore maybe there's less ventilation. But the fact is that it's on the steeper part of the compliance curve, so you'll always have greater ventilation there. So that's good. What happens at low lung volume? So what happens under anesthesia to this curve for low lung volumes?
So at low lung volumes or under anesthesia, you sort of move further down the compliance curve because like the base of your lung tends to collapse as your diaphragm's moving up for various reasons, which means that the apex of the lung, or if you're lying down supine, like the anterior part of the lung, actually is on that steeper part of the compliance curve and has, better ventilation.
Yeah, good. So airway closure only occurs at very low lung volumes in young, healthy people. So why is it that elderly people then have airway closure?
So my understanding is that it's because you've got just physiological destruction of your elastic tissue, so your airways tends to collapse.
Fantastic. That's
expiration.
That's exactly what I've got as well. Aging lung loses its elastic recoil, so intrapleural pressures are less negative, and they mimic the situation at low lung volumes in the elderly. That's great. Again, please ask any questions as we're moving through this. So I'll again put these up here. What is closing capacity? What is a capacity versus a volume? Does closing capacity depend on body position? And can you draw a graph of FRC and closing capacity with age versus lung volume as the X and Y axis? So there's a pretty common graph. I think it's in either Nuns or Wests. Have a go at answering these questions.
So closing capacity is the lowest lung volume at which closure of small airways is observed to occur.
And what is a capacity versus a volume?
So I'm going to take a punt at this. So I think a volume is potentially a dynamically changing volume, whereas a capacity might be fixed, but I feel like I'm not.
That's right. Have you seen the spirometry volume loops?
Yes.
Yeah, and so you'll find that a capacity is just comprised of two or more volumes. And so closing capacity, what's that a combination of?
Closing capacity. So it's going to be made up somewhat of residual volume, and then it may or may not begin to encroach upon your expiratory reserve volume, depending on whether it is. So it'll probably be some of your expiratory reserve volume, and depending on whether closing capacity is greater than your FRC, it can potentially encroach into part of your tidal volume as well.
Yeah, good. And you'll know this now. You're exactly right that it's residual volume, potentially plus an extra amount, and this extra amount that encroaches upon the rest of your expiratory reserve volume and various other volumes is called closing volume. Easy to remember. So it's residual volume plus closing volume. Does closing capacity depend on body position?
So my understanding is that closing capacity does not depend on position, but your FRC can change with position, and therefore the ratio of the two can become clinically significant.
Absolutely. And what's that graph that we always see drawn?
I've drawn a graph. I don't know if it's the right one, but importantly, it's a pretty, sorry, the brightness, there we go. So I guess the most important point, so I've got age on the x-axis and then FRC or closing capacity in volume on the y-axis. And I think the important point is the crossover at which FRC is greater. Mm-hmm. Yeah, I haven't quite drawn that.
That's right.
But importantly, I think it's at 65 years old in a supine patient where they're approximately equal, and maybe 75 years old in an upright patient at which you can expect closing capacity to be greater than or equal to functional residual capacity.
It's interesting. I've got the values of, I think, 44 and 66. So at 44 years of age, when your FRC when supine is equal to your closing capacity, and then this worsens. So when you're, I think, 66 years of age, FRC when you're upright will equal your closing capacity. Are those the numbers that you guys have as well? Just so I don't tell you.
I'll have to hunt down my other notes to see what I've got stuck there, but you're probably right.
Good. So that's that. So what is this problem? Like, why is it a problem, Mason, when closing capacity encroaches upon FRC?
So it's particularly relevant to us in clinical anaesthesia that when we have patients positioned supine for surgical procedures and additionally under the influence of anaesthesia, which can further decrease FRC, that if and when closing capacity is greater than functional residual capacity, you'll get closure of small airways, collapse effectively resulting in shunt, which will result in venous admixture and arterial hypoxemia.
Fantastic. And as you mentioned, this causes shunt, and that's one of the main causes of hypoxemia. Yeah, good.
Actually, can I just ask, if you were asked that in a Viva, would you save yourself 3 sentences and just say closing capacity greater than FRC causes shunt?
Yeah, I think so. I think
yeah, okay. Because like I feel like I talked a lot there and I didn't really say a whole lot.
It's a really good technique will be to firstly examine other people. So, you know, as you're moving through this, I want you guys to make Vivas based on this stuff, like, you know, make the first couple of things obvious, categorization things, definition things, construct your own Vivas, and then get more and more complex with them by just looking up stuff in nuns that are esoteric, just to make it a bit more interesting. But then once you do that, you can record yourselves doing it. You can see how other people answer. And as an examiner, because you want your mate to get through this, you'll find this thing where you're like, oh, I just want them to say the answer quickly and move on. Hence listing an answer. Like if I told you the causes of, Mason, what are the causes of hypoxemia? How'd you answer that?
Oh, sorry. So I'd say low inspired oxygen tension, decreased alveolar ventilation, VQ mismatch, and or shunt.
One more?
I feel like I'm missing something big that I should.
That's right. It's not big, but it's hard to sort out, and it's pre-existing often. So diffusion abnormality, but that's not my point anyway. You gave me those, and now I can ask you detail about it. So that's a very good way, you know, just a good way of getting through things and showing that you just know the answer to move on. Yes, no, but that was that point that you'll feel like you need to be more verbose than you need to, and often you don't. But that's a small thing.